Good day, everyone. I'm Dr. John Ward, Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health here in Atlanta, Georgia. It's my pleasure to welcome you to our webinar today, where we'll be exploring the importance of eliminating hepatitis B, starting in that first day of life for newborns here in the United States, and to really recognize the power of timely hepatitis B birth dose vaccination and related strategies that eliminate mother-to-child transmission of hepatitis B virus. And we'll show you why that's particularly important for the United States and how it's done, at the state and local level in collaboration with local clinical and other community partners. As you see there, we have two webinars, one today and then one tomorrow, and we encourage you to come and participate in both. So again, a welcome and thank you for your interest in prevention of hepatitis B starting in the first day of life for infants in our country. Please submit questions to the Q&A function of Zoom. The webinar is being recorded and will be posted at our website at globalhep.org and will be available on our YouTube channel. The slide presentations will also be available on our webinar page of globalhep.org. And while you're there, please sign up to our newsletter so you can get information about upcoming webinars and other content related to your work. So this is just where you can get that information. Very briefly, what is the Task Force for Global Health? It's an organization that was started 40 years ago by former CDC directors to begin to address global health challenges, beginning with the access to safe and effective safe and effective immunizations, including hepatitis B vaccine. It's then grown into a variety of other global health activities, including managing disease elimination programs for polio, neglected tropical disease, and with that body of experience here at the task force, I moved over after serving as the director of the Division of Viral Hepatitis at CDC to start the coalition about 5.5 years ago. Next slide, please. And the coalition, has a mission of strengthening prevention, diagnosis, and treatment to achieve national and global goals for hepatitis elimination. We seek to do that in 3 ways: bringing together key partners to exchange lessons learned and other information that can help each other do our work, such as our webinar really exemplifies that convening of key partners. We strengthen the evidence base. We've developed national hepatitis elimination profiles. We conduct technical assistance and operational research. And then we outreach to national governments and global organizations, including WHO and the United Nations, to strengthen the advocacy to build the resources needed to deliver effective hepatitis prevention care and treatment services, including in the United States. Next slide, please. So here's our agenda for today. I'll give you a brief sort of basics of eliminating mother-to-child transmission of hepatitis B. Then we'll be hearing from Julie Lazaroff, who's a perinatal hepatitis B coordinator for New York City, Jenny Grilly, who is the hepatitis unit supervisor in the Minnesota Department of Health, and Dr. Laura Hagelmeyer, pediatric hospitalist and newborn nursery medical director at the University of Minnesota Masonic Children's Hospital. Next slide, please. So let me give you a little bit of background. So we're all on the same page. Hepatitis B is caused by the hepatitis B virus, which is a blood-borne virus that can persist as a chronic infection, and with that chronic infection, slowly inflames the liver over time, leading to scarring or cirrhosis and the onset of liver cancer. Um, Hepatitis B is the major cause of liver cancer around the world. Liver cancer is the third leading cause of cancer deaths worldwide. There's about 250 million people living with hepatitis B around the world. Countries in Asia and Africa have the highest prevalence or largest burdens of hepatitis B. In the United States, there are about 640,000 people living with hepatitis B. Most of those persons were born in those high prevalence countries in Asia and Africa. Next slide, please. Now, an important element of the mode of transmission and natural history of hepatitis B virus is that the greatest risk of becoming chronically infected with hepatitis B virus and then having that severe liver disease and liver cancer in the future is for young children, particularly newborns. Once infected, 90% remain infected. For infants, it's a little bit lower, about 50%, and only 5% for people who are adolescent and adults at infection. So the critical vulnerable population to reach are newborns to interrupt that transmission from mother to child. Because once infected, 1 in 4 will die prematurely from liver failure and liver cancer in later life. And that's the health outcome we're seeking to prevent. Next slide, please. Fortunately, we have a hepatitis B vaccine. It's the world's first vaccine to prevent cancer, liver cancer. Since 1992, it's been recommended as a routine infant immunization here in the United States as well as worldwide. In 2005, CDC recommended that this vaccine be delivered in a timely way for all newborns in the United States. Multiple studies have shown the vaccine to be highly effective in preventing mother-to-child transmission, about 75%. Traditionally, it's been if the mother is known to be infected, the infant is also recommended to receive hepatitis B immune globulin immediately after birth so that you can increase that prevention effectiveness even more. More recently, women with high viral loads have been recommended to receive antiviral prophylaxis with tenofovir to lower that viral load and increase that prevention as well. The vaccine provides long-lasting protection, at least 40 years of protection after birth dose and infant immunization. Booster doses are not typically indicated, and the vaccines have excellent safety profiles. Next slide. Now, with the scale-up of infant immunization, which prevents transmission from one person to another through incidental blood exposures, an increasing percentage of transmissions now are from mother to child. That certainly is the case in the United States. And so that's why we're speaking of it today, to emphasize the importance of protecting newborns from hepatitis B virus infection. Next slide, please. So what you have here, you're seeking to bring together a combination of interventions. You want to have high coverage with hepatitis B vaccine. That includes a birth dose within 24 hours of life, followed by completion of the 3-dose vaccine series. You want to be screening all pregnant women to identify those who have hepatitis B to assure that their infants are receiving hepatitis B vaccine and hepatitis B immune globulin, and if the mother has evidence of high viral load, antiviral prophylaxis. Next slide, please. So this is the basic constellation of interventions that I just mentioned. screening to identify pregnant women with hepatitis B, antiviral therapy for those with high viral loads, uh, uh, hepatitis B immune globulin, and then that infrastructure that of all infants um, receiving timely hepatitis B birth dose vaccination, followed by completion of the infant 3-dose series. Next slide. Some may ask, why do we recommend all newborns receive hepatitis B birth dose um, 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 while you're also screening pregnant women to identify those who are hepatitis B? Well, first of all, there are a large number of pregnant women who do not receive that testing, and so their infants. Um, it's not known if the infant's being born to a mother with hepatitis B. Not all of those exposed infants or pregnant women with hepatitis B are identified in a timely way for the perinatal hepatitis prevention programs that you'll be hearing about in a moment, are able to manage their preventive care. Um, um, and um, 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 so the birth dose is really a safety net to make sure that the newborn is receiving that preventive service to maximize their protection, um, rather than relying on some other bit of information before delivering this safe and highly effective vaccine, which prevents mother-to-child transmission as well as protecting the infant in the first months of life before that second dose of hepatitis B vaccine is available and delivered to them as part of the infant immunization series. Next slide, please. Our birth dose coverage has slowly increased over time. It's about 76%. The WHO target is 90%, which a number of countries around the world have achieved. So we still have some work to do to improve our hepatitis B birth dose coverage. Next slide. So let's see how prevention of mother-to-child transmission is done, and we have several examples that we'll be sharing today and more tomorrow. And I'm going to turn it over now to my colleague Julie Lazaroff, who's the perinatal hepatitis B coordinator for New York City Department of Health and Mental Hygiene. Julie?
Thank you, Dr. Ward. Can you hear me?
Yes.
Okay, great. So good afternoon, everyone. And my name is Julie Lazaroff. I'm the unit chief in the perinatal Hep B prevention unit here at the New York City Department of Health, and we are housed in the Bureau of Immunization. Today, I'll be speaking about perinatal hepatitis B prevention in New York City. Next slide. Thank you. So the Perinatal Hep B Prevention Program is a national grant-funded program supported by the National Center for Immunization and Respiratory Diseases at the Center for Disease Control and Prevention, and this program has been in place since 1990. The central mission of the program is to prevent perinatal hepatitis B infections. The program has 4 central objectives: to identify hepatitis B positive pregnant and postpartum patients, which we call cases, through public health surveillance methods; to ensure administration of newborn post-exposure prophylaxis, which consists of the hepatitis B vaccine and the hepatitis B immune globulin within 12 hours of birth; to conduct follow-up timely completion of the 3-dose Hep B vaccine series by tracking vaccinations and working with pediatric providers and families to ensure that appointments are scheduled and kept; and then finally, to provide case management to ensure that post-vaccination serology testing for hepatitis B is completed on time and to monitor the infant outcomes. And next slide. So the first objective, to identify pregnant patients with hepatitis B, is supported by multiple public health requirements and recommendations. In New York State, including New York City, Public Health Law 2500E was established in 1990, and it requires prenatal screening for hepatitis B surface antigen, which is the most reliable indicator of infection, and reporting to public health hepatitis B infected pregnant and postpartum patients. It also specifies that prenatal providers record the test result and date of collection in the prenatal record so that it is available at the time of delivery for staff to review, and this is for all patients. Furthermore, patients admitted to delivery facilities with an unknown hepatitis B status are required to be tested immediately upon admission so that results are returned within 24 to 48 hours. Also, the maternal surface antigen result is required to be recorded in the infant chart as well as on the newborn metabolic screening form. The latter provision serves as a universal method to document the maternal Hep B status for all newborns, and positives are reported to the public health departments in New York State. So, in addition to these legal requirements, over the years, other recommendations and development of more refined surveillance methods have been found to be important for the success of the work. The first is for the prenatal care provider to forward a copy of the original lab report instead of transcribing the result into the prenatal medical record, and this minimizes the likelihood of transcription errors. And in the same way, for the delivery facility to move the original copy of the lab report from the maternal prenatal record into the infant chart. Also, the CDC recommends that pregnant patients who may have been at risk for hepatitis B infection during pregnancy after their initial screening be tested again for Hep B upon admission. This includes patients who had more than one sex partner in the previous 6 months, were evaluated for an STD, engaged in IV drug use, or had a positive Hep B positive sex partner. And perinatal Hep B programs may also employ enhanced surveillance methods. Unfortunately, I don't have enough time to go into those today. And next slide. So this chart shows the number of births to Hep B positive birth parents reported to the New York City Perinatal Hepatitis B program and confirmed from the year 2003 to 2024. The range of annual cases is 545 to 1,978, with the highest number of cases in 2007. Since that time, the number of cases per year has been trending downward, with the lowest number of cases of 545 identified in 2024. And next slide. So this slide shows the hepatitis B vaccine birth dose coverage for all newborns in New York City from the year of 2013 through 2023. And it is similar to the national trend. However, the 2020 Healthy People goal was for 85% of newborns to receive the Hep B vaccine within 24 hours of birth. And the birth dose coverage in 2013, as you see, was 66%. And we did have some gradual improvement of almost 78% in 2019. But we have seen a decline since the years of the COVID pandemic, presumably due to some increase in vaccine hesitancy. That's not, I don't have a published study about that, but it has been a trend for all childhood vaccinations. And then with a birth dose coverage of 74% in 2023. Thank you. And next slide. So, through conducting outreach with high performing birth dose facilities and reading available literature on the subject, the New York City program has identified the following best practices for improving hepatitis B birth dose acceptance by families at the time of delivery. First, to provide education about the Hep B birth dose during pregnancy. And second, to remind the birth parent and other family members about the Hep B birth dose at the time of delivery. Then to offer the Hep B birth dose in labor and delivery or in the postpartum unit, and not to wait until the newborn is separated from the parent in a newborn nursery if possible. Also, pediatric providers should recommend that the newborn receive the Hep B birth dose inpatient and not wait for the first outpatient visit, and explain the rationale to the family. Also, inpatient pediatric providers should counsel families who are vaccine hesitant by listening to their concerns and providing evidence-based facts about safety and efficacy. Finally, if the family does decline the Hep B birth dose, the delivery facility should require the family to sign a declination form. And next slide, please. I will now discuss 4 case studies that occurred in New York City when maternal hepatitis B infection was not identified at the time of admission to the delivery facility, though the infants were case managed by the New York City program after delivery. In all 4 cases, because of a universal hepatitis B vaccine birth dose policy, all 4 infants did receive a birth dose within 24 hours. And next slide. Okay, so case study number 1, we had, this was where we had a prenatal surface antigen positive test result in the maternal chart. However, the maternal chart was incorrectly transcribed as negative to the newborn chart. Therefore, the newborn was not administered the HBIG. The Hep B vaccine birth dose was administered within 24 hours, and after being followed by the perinatal program in New York City, the 3-dose vaccine series was documented to be completed on time, and the child tested immune at 9 months of age. And next slide. So case study 2 is where we had, it was when a prenatal surface antigen result for a Hep B positive patient was unknown at the time of delivery, and the patient's prenatal medical record was unavailable at the delivery facility. This was actually during the COVID pandemic, and the expected delivery facility was actually dedicated to COVID patients only. So that patient had to go to a different delivery facility that did not have the prenatal record. The maternal surface antigen testing was the blood was drawn and was ordered at 24 hours after delivery, and the test result was unavailable at the time of infant discharge, though it was eventually reported as positive. The Hep B vaccine birth dose was administered within 24 hours. However, the HBIG was never administered because the family could not be reached. The perinatal program in New York City did follow up with the family, and the vaccine series was completed on time, and the child tested immune at 1 year of age. So we have case study number 3. This was where the birth parent was surface antigen negative. However, they had elevated HBV DNA levels during pregnancy. This is referred to as an occult hepatitis B infection. The hospital protocol at this particular delivery facility is to, or was at the time, to only give HBIG to newborns if the birth parent is surface antigen positive. And this is very often the case where the protocol is to review the surface antigen test result because that is the test that's required during pregnancy. However, the birth parent and the pediatric provider knew of the birth parent's hepatitis B status, and they insisted that HBIG be given at day 2 of life when they discovered that the HBIG had not been given. The Hep B vaccine birth dose was administered within 24 hours of birth, and the 3-dose vaccine series was completed on time, and the child tested immune at 10 months of age. So finally, in case study number 4, this is where we had a case identified prenatally by the New York City Health Department, but the patient declined Hep B education from the health department staff. The prenatal surface antigen positive result, it was in the maternal chart. However, again, this one was incorrectly transcribed as a negative to the newborn chart. The New York City, the program contacted the delivery facility to inquire if the newborn had received the post-exposure prophylaxis, and the child was still there. And then upon questioning by the nursing staff, the birth parent insisted that they did not have Hep B. The Hep B vaccine birth dose was administered within 24 hours of birth, and then eventually the HBIG, after finding the positive test result by the staff, the HBIG was administered at 2.5 days of life, And then the 3-dose vaccine series was completed on time, and the child tested immune at 10 months of age. So quickly, to finish up my presentation here, I just want to walk through the recommendations to protect newborns against errors in identifying Hep positive birth parents at delivery. So during the prenatal period, facilities should provide in-depth education to Hep positive patients regarding the need for the birth dose and the HBIG to be administered within 12 hours. Also, to instruct the pregnant patient to notify delivery staff of their Hep B status, as they do not always deliver at the expected delivery facility. At delivery facility, facilities should administer a Hep B birth dose to all newborns to provide a safety net for high-risk infants, particularly if the maternal Hep B status is incorrectly uh, recorded. And then to not transcribe Hep B test results from the maternal to the newborn chart, but to instead include a copy of the original maternal lab report in both the maternal and the infant charts. And then training staff on reviewing maternal Hep B test results, because the nomenclature can sometimes be confusing between the antibody and the antigen, and to have more than one person to verify the results, both in the labor and delivery and the postpartum or newborn unit, perhaps, to incorporate redundancy and prevent errors. And then where you have a Hep B surface antigen status that is unknown at the time of delivery, to always administer Hep B vaccine to those newborns within 12 hours, not 24 hours, within 12 hours, to test the surface antigen unknown patient's stat upon admission, not to delay, to ask the birth parent about their Hep B status if they know if they have a history of Hep B infection, and if there is evidence suggestive of maternal Hep B infection, that the newborn should be managed as if exposed to Hep B. For newborns with birth weight less than 2,000, uh, facilities are to also administer the HBIG by 12 hours unless the maternal surface antigen status is confirmed negative by that time, and if the birth weight is greater than 2,000, to administer the HBIG by 7 days or by hospital discharge, whichever occurs first. And that's the AAP, the Association of American Association of Pediatrics, or also, if discharged, to document contact information for both the family and the newborn's pediatric provider, and notify the birth parent and staff that the surface antigen result is pending, and that's the CDC's recommendation. So next slide, I just want to acknowledge the staff here in the Bureau of Immunization, Dr. Crouch and Dr. Rosen, and then all of the staff in the BOI's Perinatal Hep B Prevention Unit who have supported this work and to whom I am indebted for their support and all of their work. Thank you.
Thank you, Julie. We have a couple of questions. I'm going to get your response to, particularly the one related to home births. There was also a question to start off with about the timing of hepatitis B birth dose and how quickly it can be given. And the answer is it can be given immediately after, birth. Thailand, for example, which has an excellent hepatitis B vaccination program, the median time between birth and vaccination is 40 minutes. Which and Palmer Beasley, who was the medical epidemiologist who did some of the early studies of hepatitis B birth dose vaccination in the 80s, I once asked him that question, and he said hepatitis B vaccine should be given at the time of the first washing of the infant. You wash the infant and then you vaccinate, and that's how quickly it can be given. You can comment on that, Julie, but I also was particularly interested on your practical experience with home births, and what are some of the options of assuring a timely hepatitis B birth dose as possible for those newborns?
Sure. So we don't have a lot of home births among our caseload, so we just manage the pregnant patients who are hepatitis B infected, but we have had missed HBIG in some of those cases, even though there aren't that many. So I would say that the risk is higher. And also perhaps just a refusal of those patients to receive the Hep B birth dose, even if they're, among those who are not infected. Though I'm not sure, but just anecdotally. And the other issue is that to have the Hep B vaccine on hand is routine, even for you know, midwives who deliver home births. However, the HBIG really would need to bring the newborn to the delivery facility. The good news on that is that can be given up to 7 days. But we've also had some issues with reporting. So the issue of home births comes up probably every 2 years at our river site visits, and there still hasn't been, a comprehensive outreach on, to um, those instances to the um, professionals doing those home births. So it's something that
Okay.
probably we should do.
Okay, very good. That may come up again at some other presentations and discussions. So let's move on. But thanks again, Julie, for an excellent
Thank
overview.
you. Thank you so
Appreciate
much.
it very much. Um, let's turn to Ginny Grilly, who's the Hepatitis Unit Supervisor at the Minnesota Department of Health. Ginny, welcome.
Great. Thanks so much, Dr. Ward. So, yeah, my name is Jenny Greeley. I'm the Hepatitis Unit Supervisor at the Minnesota Department of Health. And I was lucky enough to start my full-time career in public health working on perinatal hepatitis B, and I'm even luckier now to supervise that work. So if we want to hop to the next slide. So I'm going to try to kind of keep it high level because Dr. Ward and Julie both covered quite a bit. So going to kind of talk a little bit more about kind of the quote unquote Minnesota experience. So as Julie said, the perinatal hepatitis B prevention program began in 1990 with the goal of identifying and treating infants that are born to persons who are pregnant and living with hepatitis B. So when we think about sort of the scale or the size of this program, and again, we're focusing on people who are living with hepatitis B and their infants and young children. So in that realm, in that kind of realm of thinking, we've got about 6,000 pregnancies that had due dates in 2022 that were followed within the program, and that led to about 6,800 infants. So that difference in numbers a little bit is multiple births. So we certainly do see multiple births in our program. But we also, that is balanced out that some pregnancies don't end with a live infant. So really that discrepancy is in that there are a lot of pregnancies that we don't hear about until the pregnancy has ended and we've got a baby. So there are certainly, more infants often than we're following than the pregnancies themselves. And what that means is that we have people who are coming into the hospital to deliver and, bring their kiddo into the world. And we just have to hope that the hospital knows about that family. Because part of our work is, making sure that as many people as possible who are involved in the care of this parent-child pair are aware of kind of what's at stake in the world of hepatitis B. So in Minnesota, we send notifications to hospitals. We make sure that they're aware, but we can't do that if we don't know about the pregnancy. So let's go to the next slide. So when we look at some of our national data, we're going to go back to 2021 because we've got to give these babies time to be born, time to get their vaccines, time to get their testing, and then be able to evaluate their outcome. So that's going to be a longer period of time. So looking back at 2021, the national average per public health jurisdiction, which is a little bit more than the number of states that are out there, because we have some large cities, we have U.S. territories. So we're talking a little bit more than 50. But the national average per jurisdiction is about 111 infants. So we have some jurisdictions that have like 3 babies a year that they follow. We have some that are, over 1,000. So quite the range. But when we look at what the timely post-exposure prophylaxis, so the HBIG and the birth dose that's given to these infants who are born to hepatitis B positive parents, how many do we get done there? That national average is about 84.5%. And then we look at how many do we get vaccinated by 12 months. That's our next sort of time point that we're really shooting for. Really, they should be completing the vaccine series at 6 months of age, but that gives them a little bit of extra time, and a little bit of grace when we're talking about how do people compare at the national level, and that's 88%. And then PVST, post-vaccination serologic testing, where we're looking to see if our kiddos are protected from hepatitis B or infected with hepatitis B. And then whether or not we actually get that even completed, where we're going to see them drop off over time. And you can see that that number drops quite a bit as well. So Minnesota, we are lucky enough to have, a really robust program. So we have providers who are very, very engaged in the work that we do. We have been, working towards these types of numbers for a very long period of time. So you can see that the vast majority of our infants get the shots that they need at birth on time. So this 99.7% represents, usually about 3 to 7 infants or so who don't get those shots in a timely manner at birth. And then we have, pretty good, we have very good completion of vaccine by 12 months of age. And then PVST, that testing, it drops off even for us too, even though we really do have a relatively strong program with really engaged providers. And Minnesota, you might be surprised to be in one of those upper numbers, but it's really just because of the populations that we serve in Minnesota. So let's go to the next slide. So in Minnesota, at any one time, we're usually following about 100 to 150 pregnancies, so persons who are known to be pregnant living with hepatitis B. We see between 300 and 400 infants born each year into our program. Just like with the trend data that you saw for Julie's jurisdiction, we are seeing declining numbers of births. Which we, really hope is just that we've got fewer people out there with hepatitis B. But a lot of that story is about immigration into the U.S. and how that looked over time. In Minnesota, we see about 0 to 3 perinatal infections each year. We had a very, very good run for a nice long period of time where we had no babies infected for like 5 years in a row. Hasn't been the case in the last few years. We have seen a few infections, unfortunately. But a lot of times those instances are individuals or babies who got the shots that they needed at birth. And so we have to keep kind of digging in to be able to understand the full story of what's going on there. So a little bit of just overview about Minnesota. We're a centralized state, which means that all of our case management starts at the state and then it goes out to local public health departments. We have 2 counties that cover almost 50% of the cases, and 80% of our cases are in the 7-county metro area. So all that to say that we're a very kind of tight program in one part of the state. So if you want to go to the next slide. In Minnesota, we have a large refugee and immigrant community. We have the largest Somali population in the U.S. and the second largest Hmong population in the U.S. And both of those populations are disproportionately impacted by hepatitis B. So these are kind of, it's the pieces of the story to understand about why Minnesota has so many cases. But these are very tight-knit communities too. So, it's targeted educational outreach events and things like that really can go a long way because they are tight, close-knit communities in a small geographic area. So again, just some more data where you can see that, we have a lot of racial groups presented here, but primarily our Asian and our Black populations are disproportionately impacted. And we assume that the vast majority of those are born outside the U.S. Non-U.S. born populations is 61%, but with a huge, huge number of people where we don't know where they were born. So of the people we have information about where they were born, 95% of them were born outside the U.S. So as we see changing trends in immigration over time and refugee populations coming in, it's really important to know where they're coming from and, what the risk of hepatitis B is in the countries where they themselves were born. So if we want to hop to the next slide. So in Minnesota, again, just kind of trying to center us as we think about some of our numbers here. We have about 28,700 people living with chronic hepatitis B. If you want to go to the next slide. we can see what those racial disparities look like when we graph them in a way where we can talk about them side by side, which is by looking at the rates per 100,000 persons. So again, just another thing to show hugely disproportionate impact on our Asian Pacific Islander communities and our Black and African American communities. So it's really important that we have all of this as we're thinking about the realm of hepatitis B, that we know who our communities most at risk are. But it doesn't mean that our work stops there. So let's go to the next slide. So we know that when we're talking about the realm of people living with hepatitis B, that without proper post-exposure immunoprophylaxis, which means without our babies getting those 2 shots at birth, when they're born to a hepatitis B positive parent, about 40% of those infants will become infected with none of that care happening. It's much better if they get one of them. Obviously, much, much better if they get both of those shots. So this is the best worst statistic in my world, is that the risk of parent to child transmission is 10 to 90% if those shots are missed. So again, best worst statistic, because that's almost all the percents, and really doesn't help as we think about risk. So I say that to also kind of ground us in conversations that we have with parents where there is a hepatitis B positive pregnant person. Some of those conversations are difficult, and we do even see families who are hugely at risk wanting to skip those shots. And because we've got this terrible statistic in front of us that doesn't help us really understand without additional testing what the risk is for these infants, it makes it really difficult to have these conversations, even in instances where we see individuals who are at an incredibly high risk of passing this infection onto their infants. We absolutely do have persons living with hepatitis B who refuse these shots for their infants at birth. And we know that there is a risk of infection there. So you can all imagine how it is to have these conversations with individuals who know that they don't have hepatitis B. And when we center it, only around birth, instead of talking about the fact that second an infant leaves the hospital, they're at risk in the larger world that they live in, household members, anything like that. It makes it really, really difficult to have these conversations. And so we know that the risk of transmission is incredibly low when we get these kiddos the proper shots. And I don't have slides because these are really anecdotal stories because they're before my time, but we do have 2 very noteworthy instances in Minnesota where we had infants that were born to hepatitis B positive parents. In one instance, we knew the birth parent had hepatitis B and the shots at birth were missed. That baby ended up going into liver failure. Thankfully, as best as I can tell, again, it predated me, but as best as I can tell, they did recover. I'm not sure whether or not they ended up needing a liver transplant at a very young age. Our other kind of instance that is really at the heart of our work, we had an infant that was adopted from the South, so geographically not close to Minnesota. And they were born to a hepatitis B positive parent, but because it was an adoption situation, it just wasn't caught. And this wasn't, many years ago, some years ago, 2009. So may feel like a long time for some of us, but in 2009. And unfortunately, that infant, again, was not identified as being at risk. They didn't receive shots at birth. And at 9 months of age, that infant went into fulminant liver failure and they passed away from hepatitis B. And so those are really short-term immediate impacts, and we absolutely can see long-term impacts as well. We expect that infants who acquire hepatitis B, especially early in life, will go on to have, much more negative health outcomes. I believe the statistic is that 1 in 5 will die prematurely from their hepatitis B infection. And that may not be at 9 months of age. That might be at 30 or 40 or 50 years of age, but it is a shortened life for that individual because of a very preventable disease. So if you want to go on to the last slide here. So we know how to prevent hepatitis B in the world where we have parent to child transmission. We've got a program that's been in existence for decades. We've got people like Julie who have been doing this work for 20 years and know how to do this work. And they know all the people in the game at the hospitals and clinics and things like that. But we also, have this whole other world where we have infants who are born in these situations where we could see misinterpretation of test results. We could see maybe the birth parent being negative or other members of the household being positive. Just a misunderstanding of the risks around how hepatitis B is transmitted. And so it's just vitally important that we get that birth dose done for families. So we have worked, with hospitals in Minnesota assessing what their birth dose rates are. We find that they're actually relatively decent, and that when we do see some of the lower numbers, it's often because of documentation errors and things like that. So, some of these gains may feel very small in some ways because some hospitals are really knocking it out of the park pretty well. But we really do have to focus on those areas where, even though it's maybe small gains, anything to get our birth dose rates up by a little bit. So even in hospitals that are performing really well, trying to find where those gaps are. And especially if we're seeing a lot of refusal or folks who want to wait to do that first dose of vaccine, really making sure that we're having the conversations. And I also want to note chronic hepatitis B surveillance is not funded at the national level. So what that means is that we're relying on public health jurisdictions who are not adequately funded to do everything that they can to find individuals living with hepatitis B, and check whether or not they're pregnant, and then enroll them in the program. So doing a lot of that work, when we don't have the funding for that first step of finding hepatitis B, makes it very, very difficult. So I will end with one more little anecdotal story that, in true public health fashion, is actually about my own kids. So for my first pregnancy in 2015, I refused the birth dose because I knew my own risk. I knew where my kiddo was going to be. I knew about family members. We are all very engaged in healthcare. So I knew what was going to be surrounding my child. And so I said, we're not going to do it. And we're going to see what conversations happen, because I love very close to me case studies. And no one talked to me about birth dose. So I stated it early in my pregnancy. I think we're going to delay. I think we'll wait to her first pediatric visit. Stated it in the hospital, and there was never a conversation that occurred. For my second kiddo, we got her birth dose in 2018. But, a similar scenario, very, very little conversation around, the fact that that was a decision we would have to make, and any, guidance around how to make that decision. And so, it really goes to show that we have a long way to go. I hope I'm done with kiddos, but I hope, 10 years out from my first kid, that we are in a better place. But we also do know that there is a lot of work left to do here. So I will end there and pass it off so my hospital colleagues have a chance as well. Thanks so much.
Thank you, Jenny. Great overview. Let's turn it over to your colleague there locally. If we could have the next slide, I'll turn it over to Dr. Laura Hagemeyer. This is all about a partnership between local health departments and clinical care providers, and we'll hear from Laura about her role in that partnership. Thank you.
Thanks, Dr. Ward. And Jenny, thanks for the reminders of the importance of those conversations. Even when we think that our patients are well educated, it's important to remember those conversations need to be had. As mentioned, my name is Laura Hagemeyer. I am a pediatrician and the newborn nursery medical director at the University of Minnesota Masonic Children's Hospital. And I'm excited to talk to you about some of the nuances of newborn care as it relates to hepatitis B vaccine and some of the other newborn interventions that happen in the newborn hospital. Next slide. So being the first provider to care for a newborn is an amazing honor, privilege, and also a challenge. As you can imagine, there is so much going on in those first few hours of life. However, it is a really unique opportunity for us to provide ongoing assessment, education, intervention, and health prevention for all newborns that really does affect their trajectory of healthcare going forward. So what happens in the newborn hospitalization affects what happens at next clinic visits and the family's ability and desire to continue interacting with the healthcare system. So it's really important to get off on the right foot. So as a provider, there's a lot to think about. And maybe, Jenny, this goes back to why your providers didn't talk about hepatitis B. But there are so many things that we have to think about. First of all, as we've seen on previous slides, the infant's health can really be affected by maternal health conditions. Hepatitis B is one of these things, but many other maternal health conditions can impact the health of the infant and affect our decision making. If you think about it, these babies go from relying on the placenta and the delivering parent's body for most of their physiology to needing to do it all on their own in a matter of seconds. As soon as that cord is cut, boom, they're on their own. If you want to talk about learning to fly, that is about the time they have to do it. And their physiology is changing minute to minute which makes it really interesting to provide medical care to these infants. And not only are their bodies adjusting to life on the outside, like I like to tell parents, but they've never been examined by a provider before. They may have had ultrasounds, they may have had prenatal testing, they may have had some information that we think about some conditions that may be happening, but they've never been hands-on examined, which gives us a really unique opportunity to identify pathology and identify additional challenges that these babies might have. And lastly, it's not only an intense physical transition, but an emotional one as well. Welcoming a new baby into the world is a really vulnerable and stressful time for families often, but also can be described as the happiest times in their life. So our approach and our interventions during this time, like I said, are really influential in the long-term health and well-being of these infants. So as we are aware of the vulnerability and the impact we can have, it allows us to provide comprehensive care and hopefully care that will get them onto the right steps moving forward. Next slide. So just briefly, some of the additional medications that babies may encounter in those first few days of life. This is not by any means an all exhaustive list, but the eyes and thighs, as many nurses will say, are those first initial medications usually given within a few hours of birth, up to 24 hours of birth, are vitamin K, which is a vitamin that's injection that's given intramuscularly to help prevent bleeding for babies, erythromycin eye ointment, which is an antibiotic eye ointment used to prevent infections in the eye, and then the hepatitis B vaccine, as we've talked about, to help prevent perinatal and early transmission of hepatitis B infection to these infants. These are probably the most standard medications that most, if not all, babies will get in the first 24 hours of life. Additional things like dextrose, sugar that's given oral or IV, depending on risk factors and baby's needs. Sometimes if there is a risk for or identification evidence of a systemic infection, they might get some antibiotics. And then more recently, some hospitals are offering RSV monoclonal antibody or nirsevimab for RSV protection during the birth hospitalization. So there's a lot of things that families are offered or kind of given in those early days, which if they haven't been talked about previously can be a lot for families to take in. Next slide. In addition to the medications and then also reviewing the delivering parents' health history, pregnancy history, all the prenatal screenings and things like that, there's a lot of other standard screenings that are done in the newborn period. Generally, these are legislated at the state level. So each state kind of has a plan for which of these screenings are going to be done. Some of these are local or hospital system based as well. So you may see differences based on your location and the systems that you work in. But the goal of these are to have as close to universal screening as possible for conditions where early identification and treatment changes long-term outcomes for these patients. So in the US, all 50 states and US territories mandate newborn hearing screening be offered to families in the birth hospitalization. This is generally a relatively easy test to detect hearing loss and to facilitate early identification and intervention for babies who do have hearing loss. Similarly, all states have implemented some sort of cardiac disease screening or screening for occult or kind of hidden congenital heart defects. Usually this is with pulse oximetry, checking oxygen saturations for babies, but there are other some differences at the state level for what constitutes different screening. And then the newborn metabolic screen is a blood spot test that generally is run by the state health departments, looking at a variety of different metabolic, genetic, and hematologic conditions that, again, with early intervention and identification, have better health outcomes for our patients. It's important to note that the newborn metabolic screen is variable. So in Minnesota, we have a really robust newborn metabolic screening program and have over 60 different conditions that are screened on that test, but there are many states that don't have that. So when patients are born in different states, you may be missing some things if you're used to what your state offers. Jaundice screening and glucose screening are, again, not mandated screenings, but they're treatable, preventable, common newborn conditions that most hospital systems have some type of protocol or policy on how those screenings happen in the first 24 to 48 hours of life. And these just add to the things that are needing to be done in that newborn period. Next slide. As you can imagine, this seems like a lot of intervention and a lot of stuff to do for a brand new baby. And as you're a parent, just holding that baby and meeting them for the first time, sometimes there's hesitations about are some or all of these interventions necessary. This can range from kind of gentle questioning of necessity to blatant refusal of testing and screening. But really, there's a lot of different reasons that parents have hesitation. And most often parents are just concerned it is just too much for their little bodies. And even in my 14 years in practice, I've seen so many things added to the newborn and postpartum care process that these families, they have a revolving door in their hospital room. So they're just constantly, someone is in and out of their room, like we'll talk about on the next slide. But there's just so many things going on. And as each person comes in and is completing their necessary task, parents are questioning, like, how much more do we have to do? Also, you can see on the slide, there are some of the other common hesitations parents have. And when I hear these reasons, or when I sense or see hesitation or refusal or declination of certain medications that are given in those initial hours before I see the patient, it's really my cue to slow down, start asking questions, and really try to understand what is going on, which we'll talk about with some of the strategies on my next slide. So my job would be a lot easier if these conversations had happened prenatally, but I totally understand why I can't. A lot of times in the visits for the pregnant patient, much of the conversation and the education is around things that they are currently experiencing or about to experience as a pregnant person. That baby is on the inside and considered to be in a pretty safe spot. And sometimes the things that will happen to baby after they're born are kind of pushed off out of conversation. Oftentimes they are present in prenatal education booklets, or maybe in hospital tours or birth education classes, but often not in places where people can ask providers questions. So if we were able to start some of these conversations early, that would be great. Like I said, often that doesn't happen. So when I have families with hesitations, the most important things I do are sit down, get at eye level, and really use open-ended conversations and non-judgmental language to get at the core or the specifics of the concerns that people have. Once we kind of have figured out where they're starting from, I think it's really important to kind of pause and ask permission to have a conversation about them. Of course, there are things that as a provider, I must tell the risks and benefits of refusing certain medications and interventions, but also I don't need to always have those conversations at that very minute. So sometimes being able to pause and say, I'd really love to have a conversation about the hepatitis B birth dose. Is now an okay time, or would you prefer I come back and we talk about that later? And you'd be amazed at, instead of going in with your agenda, offering up their agenda, how much that opens up the conversation to maybe say, sure, let's have a quick conversation about it. Or, now's not a really great time, but if you could drop off some information, we can talk about it later. And even opening that door to prevent an immediate refusal gives opportunity to share that education. Next slide. So some of the systemic things we can do to improve uptake are, things that hopefully most of our birth hospitals and delivering facilities are doing. But if not, these are things where I think we can make really good improvements in uptake of newborn medications and screenings. So as I noted, there's a revolving door that makes it really hard to get rest for families to bond and for families to heal physically and emotionally from the delivery process. Clustering of cares and trying to get things done in a short period of time, or in as many things at one time as possible, can be really helpful to, one, help decrease stress on the infant, stress on the parents, and not allow parents to get kind of stressed or worried about all of the different times that their infant is getting unwrapped and bothered. Many hospitals will do this in kind of a bundle process, or a birth bundle and a 24-hour bundle where they have as many things as they can clustered at a certain time. But if you don't have those things in your hospital, setting the expectations, having the nurses set the expectations of this is what happens and when with families can be really powerful to give them an opportunity to have some uninterrupted time in between those clustering of cares. Standing orders where nurses are able to access medications in the moment instead of waiting for providers can be helpful. Opt out instead of opt in policies and language is also helpful. If you think about the wording saying, vitamin K and hepatitis B are two medications we give to babies to help protect them in the newborn period. We administer them to all babies, and we'll make sure we're keeping your baby comfortable is now an okay time to do this medication sounds a lot different than, can I give your baby the shot? I think it's really important to think about our words and how those things might affect how we approach families. I know we are close on time there, but additionally, making sure that our education across the community is standard to make sure that all families are getting the same information and it's not necessarily dependent on those immediate postpartum visits to provide all education. Last slide. Making sure that these babies are comfortable when this happens and families feel that we are treating their babies with care and concern can also go a really long way. Most parents don't want to see their babies in pain. So these are some of the things we can do to offer comfort to their babies during immunizations or during painful procedures, allowing the parent to breastfeed or offer sweeties or sucrose and a pacifier has been shown in many studies to provide improved pain response and decreased pain response in infants. Holding them skin to skin in positions of comfort, offering swaddling, offering topical anesthetics when possible. These things are all going to be things that help keep their babies comfortable and hopefully help families have less stress response to the care that we're giving. So partnering with these families as really early and often is a key to overcoming the hesitation that parents have with treatment of their babies in the newborn nursery. And none of us are here to harm babies. So we're all trying to do our best for the babies, both parents, staff, and providers. So trying to keep that in mind sometimes helps us keep our goals in perspective and color some of those conversations in ways that can be helpful. All right, I will pass it off to you, Dr. Ward.
Okay, thank you. That's a great overview to show how how hepatitis B vaccine has to be integrated at that critical moment that you laid out. I had two quick questions. One, is Hep B vaccine sort of included in that general approval process or agreement with the parents, or do you have to have a separate agreement for them to get that vaccine? And then separately, do you think what do you see as the role of community-based organizations to start that education process earlier than when you see the patient?
Yeah, so there's not a specific consent form or anything that needs to be signed for hepatitis B, but they do need assent. So we do need to ask families before we administer the medication. I find bundling it with our other interventions to be the most successful in saying, this is one of the standard medications that we give. However, we do have to have specific assent from families before we give that medication. The second question, I think the community education piece of things, two things. One, making sure that it's evidence-based and helpful information is really important, and not making sure it's not just anecdotal evidence, or anecdotal stories. But I think trying to standardize in a way that is accessible to families and encourages them to ask the questions early, because I find those conversations are a lot easier to have before we're sitting there with a crying baby in front of us and I'm trying to get all of these things done in a short period of time. So, whatever the education is, making sure it's evidence-based and offered, in a standard way to patients early before they, need to make that decision can be helpful.
Thank you so much. I guess in the interest of time, we will have to ring off. I think we had three excellent presenters who give you the different sort of context of the delivery in a timely way of hepatitis B birth dose vaccination. We're going to continue this discussion tomorrow. And so please join us for that. I believe it starts at 11 a.m. Eastern time. And we'll have additional case presentations then. So thank you to all the presenters again. And again, this is Dr. John Ward. I'm at jward@taskforce.org. If you'd like to contact me directly. Otherwise, please join us again tomorrow. We have an evaluation poll that would be helpful for you to complete before you sign off. And hopefully, and again, I strongly encourage you to sign on again tomorrow. Thank you again. Take care.